Hi, good morning, Phi. Welcome to my presentation. Today I'm going to be discussing one of the most common bowel conditions experienced by Canadians, IBS, or irritable bowel syndrome. And the reason I decided to do this for my topic was because my sister was actually recently diagnosed with it. She's always suffered from, abdominal cramping, diarrhea, bloating, gas, things like this. And it was only recently where, it was a definite diagnosis of IBS. And it got me really interested in the subject. It's a topic that isn't really covered in pharmacy school. So I was doing a lot of reading a lot of guidelines, and I stumbled across a pretty recent guideline update from 2019 from the Canadian Association of Gastroenterology. And I found the guideline very informative, a lot of things that I wasn't aware of. And I thought it was just a very nice consolidation of all the evidence, all the pharmacologic and non-pharmacologic modalities to manage IBS. And yeah, I'm just going to be walking through that guideline update, kind of talking about the main updates, the main evidence that was presented in this guideline, and hopefully you might get something out of it. So thank you so much for joining me, and let's get started. So I'd just like to start off by talking about what IBS even is. It's a very strange condition where the symptomatology varies drastically from patient to patient. And it's basically a chronic condition that waxes and wanes over the lifespan of the patient. Usually starts before the age of 50. In fact, if it starts after the age of 50, that's considered a red flag and requires further assessment. But yeah, basically it's characterized by abdominal cramping and bloating. Those are pretty much symptoms across all patients that, again, wax and wane over the patient's life and can either be worsened or relieved by defecation. And there's 4 subtypes of IBS depending on the type of bowel frequency pattern. So you have IBS-D, which is those symptoms I just mentioned, along with diarrhea, loose stool. There's IBS-C, which, as you probably guessed, is those symptoms with constipation primarily. And then there's IBS-M, or mixed IBS, where it kind of alternates between diarrhea and constipation, as well as IBS-U, which is the rarest type, where less than 25% of the stools are loose and less than 25% of the stools are hard. So, but regardless of which category of IBS you fall in, the diagnosis is pretty simple. It's a clinical diagnosis. There's no biomarkers or any real physical exam that can diagnose IBS. It's basically a diagnosis of exclusion. So if you exclude any other bowel conditions, then IBS might be a possible diagnosis. And it's a simple diagnosis. It's basically diagnosed if you have abdominal pain, recurrent abdominal pain, more or equal to 1 day per week for greater than 3 months. And it also has to be associated with defecation and or associated with a change in bowel frequency. So again, that IBS-U condition coming in where bowel frequency isn't really affected that much. And you have to have the absence of these red flag symptoms that I mentioned earlier, such as abnormal weight loss, nocturnal diarrhea, blood in the stool, things like that, onset over 50 years of age, family history of colon cancer. So again, it's a diagnosis of exclusion. And once you meet those criteria, you're diagnosed, and the goal of therapy is simply to manage symptoms, because this condition here does affect about 12% of Canadians and 10% of people worldwide, and it's a leading cause of workplace absences that obviously impacts the economy in a very negative way. So that's pretty much the diagnosis and symptomatology. Now I'd like to touch a little bit on the pathophysiology of IBS, which I find very interesting. Again, none of this is conclusive, but there are some pretty promising theories. Now, the core of IBS is altered gut permeability, hypersensitivity, gut immune activation, as well as intestinal permeability. So all these factors are thought to have either originated from a genetic predisposition or an environmental factor, kind of like type 1 diabetes, if you want to think about it that way. And the environmental factors range widely. There's 2 competing theories: the brain to gut axis and the gut to brain axis. So the brain to gut axis, basically stating that stuff like childhood trauma, anxiety, depression, basically psychological conditions affect the gut in this way. And the gut to brain pathway is pretty much the opposite, where things that originated in the gut, such as gastroenteritis, infections, childhood antibiotic use, things like that, activate this ascending pathway to the brain, which then in turn affects the gut in this sense. So it's a very strange pathophysiology. Haven't really, heard of anything like this. And again, research is still ongoing, but I just thought I'd touch on my understanding of the pathophysiology. So again, because IBS is an incurable condition and our goal of therapy is to minimize symptoms, there's a vast variety of therapeutic modalities used to treat IBS. And I think the 2019 guideline does a great job of just kind of breaking it down by subtype, really just going into what first, second, and third line therapy should be, and what an all-encompassing approach to IBS should be, regardless of the subtype. So starting off with global management of IBS, these three interventions are really used across the board, regardless of the subtype of IBS. And the first and most obvious recommendation is to avoid certain food triggers. Now, these food triggers differ from patient to patient, but you will know what triggers your symptoms, and it's probably best to avoid those types of foods. Usually high lactose foods, high in what's known as the FODMAP food category, which we'll get into later. But again, it varies from patient to patient. So that's the first and probably the easiest recommendation. Of course, it's easier said than done. It is kind of a trial and error exclusion process. Go without a certain food for a bit, see if your symptoms improve or relapse, rinse and repeat basically for different foods. It's a very time-consuming process, but it's something that, if you can find a food trigger, definitely avoid it. The second thing is soluble fiber. Believe it or not, soluble fiber is recommended across the board, regardless if you have diarrhea, constipation, or a mixed type of IBS. It's associated with improving symptoms of constipation and diarrhea, which is interesting. And soluble fiber includes psyllium, and we have to educate patients that soluble fiber isn't wheat bran, because many patients, when they think of fiber, they think of things like bran flakes, raisin bran, things like that, which are definitely not effective and even exacerbate the IBS symptoms. So it's important to let them know to, minimize their intake of insoluble fiber, or at least keep it at a normal level, rather than increasing it to treat the IBS. And the benefits of the soluble fiber is that obviously it's available over the counter, isn't very expensive, very well tolerated. Interestingly enough, it can cause bloating and gas if taken, if a dose is initiated too high too soon. So it's best to start with a low dose and then gradually work your way up to about 20 to 30 grams per day. And that's shown to improve, again, constipation and diarrhea, as well as being well tolerated. It's also worthwhile educating patients that they don't have to buy Metamucil. They can get soluble fiber from dietary sources such as beans and legumes, oats, barley, flax seeds, oranges, carrots, things like that. So if they're not open to trying a supplement, at least you can tell them to increase their intake of those types of foods and decrease their intake of insoluble fiber, like some certain fruits, wheat bran, broccoli, things like that. Now, second-line therapy for global IBS management would be antispasmodics, such as hycosinate, pinivarium, and dicyclamine. And these ones here are really used when pain, abdominal pain, is the predominant symptom, or when a trial of soluble fiber isn't really managing it. It's more of a second-line option. There are some problematic anticholinergic effects, obviously, such as constipation. So if your IBS subtype is IBS-C, then it's probably not going to be your first-line course of therapy. It can also cause dry mouth, dizziness, your classic anticholinergic effects. The good thing is most IBS patients are young, so these anticholinergic effects won't be as potentially hazardous as if they were elderly, obviously, but still something to watch out for. And yeah, definitely useful in improving the pain, guideline recommended, but not as first-line therapy. But again, regardless of the IBS subtype, it is a definite treatment modality. It's useful to note that peppermint oil as well is available over the counter. And just like the antispasmodics, it's recommended as second-line therapy or first-line therapy if abdominal pain is the predominant symptom. Obviously, peppermint can cause GERD, so best avoid it in those types of patients. But and it should be taken on empty stomach, so making it a little bit more convenient. A few drug interactions with the 1A2, CYP1A2, so probably not as great as the antispasmodics, but you can avoid those anticholinergic effects, so that's another option. Okay, so now switching our focus into the specific management of the different subtypes of IBS. So starting off with IBS-C, M, and U, because again, all of these components have diarrhea as a predominant symptom. So the first thing that's recommended, a little bit of dietary intervention, is called the low FODMAP diet. And a little bit controversial, but FODMAP basically means fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. And it's basically a group of foods that have shown to increase bloating, diarrhea, things like that, abdominal pain. They include stone fruits, some legumes, high lactose foods, artificial sweeteners, things like that. And yeah, the reason why these foods are problematic is because they're largely indigestible. Many humans lack the enzymes to digest these types of foods, causing bloating, gas, cramping, things like that. Other metabolites as well that might irritate the gut. So an intervention for IBS-D, M, and U is to avoid these foods for a short amount of time, about 4 weeks. It's probably best not to go beyond 4 weeks because it can negatively alter the gut microbiota. But it is good to see if those foods are triggers and minimize their consumption if that 4-week trial does show an improvement in symptoms. So definitely something to do, but not for a long period of time. Just for a short trial of 4 weeks, just to cut out all those FODMAP foods that I just mentioned. And it's best done under the supervision of a dietitian. So, of course, a dietitian isn't always accessible, but if it is, it's best to go with a dietitian. And of course, another treatment modality for IBS-D and even IBS-C in some cases is, of course, probiotics. The idea being that altering the gut microbiota might influence the gut-related immune system. And it has shown to improve bloating and distension, things like that, and improve bowel frequency. But there's a few drawbacks to probiotics as well. For one, they tend to be very expensive. Of course, they're over-the-counter, which is convenient. But patients, they're generally well tolerated, but patients might have to try a few different probiotics before arriving at one that suits them. And based on the guidelines, they recommend the lactobacillus type probiotics. But the optimal dose and formulation remain to be found. So probiotics, definitely not a first-line therapy, but a treatment option for IBS-D as well. So finally, if a patient tries the low FODMAP diet, they try soluble fiber, antispasmodics, and the IBS-D patient is still experiencing these symptoms, then a very strongly supported treatment recommendation in the guidelines is the use of tricyclic antidepressants, the TCAs. And it really makes sense why this class would be considered. First of all, they do increase serotonin, so it can decrease pain perception and decrease anxiety, depressive symptoms, which actually give rise to IBS, as well as increasing colon transit time, reducing the symptoms of diarrhea, and just overall decreased perception of the problematic symptoms. So it really makes sense why the TCAs are used in this setting. The idea is to start low and go slow with amitriptyline, desipramine, and imipramine, and the doses tend to be lower than those used for depression. Then again, TCAs aren't really used for depression these days anymore, but because of their problematic side effects. Which brings us to the side effects. Obviously, constipation in this sense would be a good thing if you're dealing with an IBS-D patient, but other things like dry mouth, sexual dysfunction, nausea, things like that can definitely are definitely a drawback to this class of medications, which makes sense why it's a second-line option in this setting. But it definitely has its place in therapy. Now switching our focus over to IBS-C. As already mentioned, a course of soluble fiber antispasmodics are recommended for all subtypes. But in IBS-C, the main player, the gold standard kind of medication in this guideline, the medication that had the most evidence to back up its use, was linaclotide, or brand name Constella. And this medication here, it acts on the guanylate cyclase C receptor to increase gut transit time and even modulate some pain receptors. So linaclotide not only works for the constipation symptoms, but also the gas, bloating, and abdominal pain. Now, the onset of action for improving the constipation symptoms are within a week or so, but improvement in the gas, bloating, and abdominal pain can take about 8 to 12 weeks for the maximum effect. So upon counseling patients on this medication, it's definitely important to give them realistic expectations of when the medication is going to start working. But Constella seems to be very, very well tolerated. Again, diarrhea being the main side effect, but it usually tends to be minimal and can be minimized by taking the drug 30 to 60 minutes before breakfast. So a very well tolerated drug, very effective. Again, the downside is it's very expensive. Without insurance, this medication can really be problematically expensive. But it seems to be the one drug that is really heralded as a good treatment for IBS-C. Second-line therapy includes the SSRIs, and similar rationale to using the TCAs for IBS-D. The SSRIs, and the doses here actually approach the doses used for depression. For example, fluoxetine 20 milligrams daily, paroxetine 20 to 40 milligrams daily, and citalopram 20 milligrams daily. So very similar to the depression doses, but again, it's a similar rationale to using the TCAs. And of course, the SSRIs, they do have problematic side effects as well, such as, again, sexual dysfunction, like diarrhea, agitation, things like that, insomnia for certain one of them. So you wouldn't want to use these as second-line agents, but they definitely have their place in therapy. Another agent that I should mention for IBS-C is lubiprostone, which activates chloride channels in the GI tract. It doesn't have as much evidence backing it up in the guideline, but it is mentioned, so just worth giving it a mention as well. But yeah, for IBS-C, the gold standard is definitely Constella, as well as those global treatment options that I mentioned earlier. Now, before closing the presentation, I should mention a few treatment options that were previously recommended for the treatment of IBS, but have now fallen out of favor. And I want to start off by talking about rifaximin, an antibiotic, a non-absorbable antibiotic that is theoretically supposed to reduce gas production by altering the gut microbiota. And yeah, this medication here has really fallen out of favor, really not a lot of high quality evidence for it. And of course, there's the potential of antibiotic resistance. So this recent guideline has opted to mention it as a medication that shouldn't be used for IBS. Another one is continuous use of loperamide, which can cause abdominal pain. Of course, using it PRN once in a while when needed isn't really a bad thing, but using it continuously for recurring diarrhea of IBS-D, definitely not recommended. As well as cholestyramine, not a lot of evidence behind that one. And an IBS-C, osmotic laxatives. Sure, they help with symptoms of constipation, but only the symptoms of constipation. So it's definitely not a globally recommended medication like Constella was in that case. As well as prucalopride, I believe a serotonin agonist, hasn't really been shown to improve IBS symptoms. So just a few treatment options that were mentioned that have kind of fallen out of favor. And yeah, I just wanted to mention them before closing out the presentation. So I think that just about covers it. Thank you so much for watching, Phi. I really appreciate it. And you take care. Thank you again for an amazing rotation. I really learned a lot. All the best.